As Connor said, I'm going to be talking about resisting RECIST, new methods of assessing tumor response to therapy. And I thought of titling this Measuring Tumor Response in a Post-RECIST World, from Black and White to Shades of Gray. Unlike these two fine gentlemen, I have no disclosures that are relevant to this presentation. I'm first going to briefly discuss the limitations, although Aslam, of the anatomic markers, then discuss some of the new criteria for tumor response in the era of personalized medicine with molecular targeted therapy and immunotherapy, and to learn when it is appropriate to resist using RECIST. Now, I must say, for probably about 80% of my practice, I still use RECIST, but when patients are on molecular targeted therapy or immunotherapy, it doesn't work. As Aslam was discussing, the anatomic tumorimetric responses are WHO, RECIST 1.0 and RECIST 1.1, and they had their zenith, their apotheosis, from 1979 to 2005. Now, traditionally, chemotherapy targets various steps in cell proliferation, such as DNA formation and function, or the mitosis spindle. Cytotoxic therapy acts by eliminating neoplastic cells. And I remember during tumor war, they would talk about log kills. You'd first have your tumor removed surgically, then you'd have adjuvant chemotherapy, and hopefully with each progressive cycle, you would kill 10 to the fourth number of cells and then ultimately cure the patient. So those were the days. You know, the tumor would remain stable in size or get bigger or get smaller or disappear. And those were the easy days. Over the last 2 decades, dramatic advances in understanding the genetics and molecular biology of tumors has revolutionized therapy for many neoplasms. And we now, this is the era of personalized medicine and individual tumor therapies with a molecular targeted therapy and immunotherapy. Now, targeted chemotherapy interferes with signaling pathways and thereby inhibits cell growth, but does not necessarily lead to cell death, unlike the cytotoxic drugs of traditional chemotherapy. With targeted agents, lack of progression and pseudoprogression may actually be associated with a positive improvement in outcomes, even in the absence of major shrinkage of tumors. And oncologists these days have become interested in the length of time that a cancer does not grow or metastasize. Progression-free survival has become the preferred endpoint for many cancer therapy trials over the last decade. So what are some of these agents? And we have to learn the names of them. Imatinib and nilotinib, these are the multi-targeted tyrosine kinase inhibitors, and they're for CML and GIST tumors. Bevacizumab or Evanston for colorectal cancer, lung cancer. In breast cancer, it's not approved in the United States, but it still is in Europe. Then multi-targeted tyrosine kinase inhibitors with VEGF inhibitors, sunitinib and sorafenib, and that's used for renal cell carcinoma, pancreatic neuroendocrine tumor, GIST tumors that are not responsive to imatinib, and hepatocellular carcinoma. Then EGFR inhibitors are lotinib and gefitinib, and those are used against non-small cell lung cancer and pancreas. Finitor, mTOR inhibitors, and BRAF inhibitors such as Zelboraf for melanoma. Now, how do you know the names? And I think it's very important that when your clinicians have a patient on immunotherapy or molecular targeted therapy, you need to know what type of agent they are. Now, we can't learn all their agents and all their activities, but if it has an AB at the end of the name, it's an antibody. So if you see a drug that has an AB at the end of it, it's an antibody, and it's a molecular targeted therapy or immunotherapy. And if there's an IB at the end, there's an inhibitor, and so that means that it may be molecular targeted therapy or immunotherapy. So I think when you see these on the requisition, you have to keep RECIST that they may not entirely work in these patients with these novel therapies. And if there's a MU in there, there's going to be murine-derived agent. So this is a brave new world that we're, with apologies to Aldous Huxley. For the last 60 years, we've been targeting tumor cells, but now, and more recently, we've been targeting the immune system. And as was mentioned yesterday, since 1908, Paul Ehrlich said that the ability of the immune system actively detects and eliminates cancers that we're probably constantly producing. Since then, T-cell reactive antigens against tumor-associated antigens have been detected in the blood of patients with many different types of tumors. This suggests a role for the immune system in fighting cancer cells. Now, the goal of immunotherapy is to restore or augment anti-tumor immune responses. Tumor immunology has led to the identification of novel targets for new immune-based approaches, including a group of cell surface molecules known as immune checkpoint inhibitors. The first checkpoint inhibitor was ipilimumab, so we know it's an antibody and we know it's mouse-derived. It was the first checkpoint inhibitor approved by the FDA for metastatic melanoma. And so this is what happens. Our normal cells say to the T cell, hey, we're friendlies, don't harm us. And unfortunately, that's good. Unfortunately, tumor cells do the same thing. They say to the immune system, hey, we're friendly, even though we have all kinds of mutations and we're cancer, and so this interferes with immune surveillance. Now, the goal of immunotherapy is to say, make the immune system, hey, maybe this is a tumor cell, we'll attack it. And so this is a novel therapy where we hype up, we rev up, we accelerate the immune system to help recognize tumor cells once again. And there are two major immune checkpoints, the cytotoxic lymphocyte-associated protein, ipilimumab, which is used for melanoma and non-small cell lung cancer, and tremelimumab. And I wonder I'm sure the guys who come up with the names for these get a lot of money because they're very difficult to pronounce, is used for melanoma, breast cancer, and mesothelioma. And the other are, I love this, PD, programmed death receptors, nivolumab and pembrolizumab, and they're used for melanoma, bladder cancer, gastric cancer, ovarian cancer, HCC. So this is coming more and more into practice. And again, I think as part of your routine, it's, unless you have an electronic medical record, and if the patient is on a novel chemotherapy, it's very important for you to know that before you dictate your exam. So in keeping with their unique mechanism of action, the immune checkpoint inhibitors have shown conventional and an unconventional response pattern, where you can have initial apparent tumor progression following by regression. So here's, this is a case from the literature. This is a patient with a melanoma, was receiving an immune checkpoint inhibitor, ipilimumab. And notice by week 12, this tumor is actually, it looks like it's gotten larger, but this is just the immune system attacking the tumor. And you can see the cutaneous lesion had grown as well, but ultimately this patient showed a proper tumor response. These patients are also getting a unique immune-related adverse effects. And these adverse effects include apophysitis, dry mouth, hypothyroidism, pneumonitis. And in this room, this very room this afternoon, I'm going to be giving a lecture on the pulmonary complications of the immune checkpoint inhibitors, hepatitis, adrenal insufficiency, arthralgias, and enterocolitis. As a matter of fact, they sometimes rev up the immune system so much that the patient actually gets autoimmunity to a lot of their organs, and you actually have to give them steroids and also Remicade and other anti-inflammatory agents to try to reduce the immune response. And this is the time course for rash, liver toxicity, diarrhea, and hypophysitis in patients who are receiving ipilimumab. So there are four major types of responses that you can see, and there was a breakfast symposium on this morning, the immune checkpoint inhibitor responses. First of all, you can have a tumor that responds like it typically does in RECIST criteria. It can get decrease in size or increase in size, or it can go away. Or you can have stable disease followed by a slow and steady decline in tumor burden. And then this is what I find most problematic is pseudoprogression. You know, I don't have gray hair just because I'm old. It's just because I have to read the scans on patients who are on immune therapy and they may have pseudoprogression. And what does pseudoprogression mean? Well, you can have, this is your baseline tumor, and it can get smaller with immunotherapy, or it can get larger with progression, or the tumor can appear larger, but it's actually the lymphocytes and macrophages attacking it. So this is pseudoprogression, and we have a large melanoma clinic at our hospital, and some days this is how I feel after reading all these cases. Here, the next major response, you can have response after an apparent increase in apparent tumor burden. So here's a patient with melanoma, and on week 12, this lesion looked larger, but ultimately it went away. And also there's a response in the index lesion, but you may have new lesions as well. So all our RECIST criteria no longer work. Then there's also the problem with tumor flare. Immunotherapy for Hodgkin disease, non-Hodgkin's lymphoma, and CLL can induce, during the first weeks, rapid, painful, and self-limited increase in the size of lymph nodes with fever, leukocytosis, rash, and bone pain. And so here's a patient who's got non-Hodgkin's lymphoma and was on nivolumab, and we can see here's the baseline lesion. It went away. But here it looks like there's some new lesions, but ultimately this therapy was successful, and this was just some chemotherapy-related lung disease. So when evaluating patients who are on these novel therapies, you have to take pseudoprogression with a grain of thought, and you also have to keep that in the back of your mind when you're reporting these patients. Now, all 4 of these patterns have been associated with a favorable survival. And I think this is the only time I've seen Angela Merkel smile is in this one image, so I thought I might show it to you. So this is the major problem when I deal with patients on immune checkpoint inhibitors. Is it true growth, which may occur before the immune system is properly accelerated, or is it pseudoprogression? There's a transient increase in the tumor size by infiltration of immune cells into the tumor. These are immune-related response criteria, and there was a RECIST symposium about this. You can have new measurable lesions, but some of the lesions may be bigger, some may be smaller, but you bring it in and factor it into the total tumor burden. Complete response is easy enough to understand. Partial response, greater than 50% decrease in tumor burden compared with baseline in 2 observations at least 4 weeks apart. They can have stable disease and then progressive disease, at least 25% increase in tumor burden compared with the nadir at a single point in time, in 2 consecutive observations at least 4 weeks apart. And as Connor was saying, at our institution, in most places, patients are now reading their report. And so I feel somewhat sheepish when I do a report and say this is of uncertain clinical significance, or you might say this may represent pseudoprogression in this patient on immunotherapy. So just to summarize the new agents that are involved, you can have immunotherapy, monoclonal antibodies against EGFR, tyrosine kinase inhibitors. This is a whole host of things. So this has led, at least for about 20% of my practice, to the failure of the conventional anatomic markers. Let's look at some examples. Here's a patient who was receiving Tarceva. This was an EGFR mutation-positive lung adenocarcinoma. And by overall size measurements, this lesion has remained the same, but actually this lesion has improved. It's far less solid. Or what do we do about these bone lesions? They're about the same size, but they're filling in. And again, this is a problem with RECIST criteria. And here's a patient who has metastatic GIST to the liver. And here's in August. And let's look at this lesion. This lesion looks like it might be getting bigger, but actually it's getting better. It's getting more cystic. And this lesion, you'd say, oh, this might represent progressive disease, or this might represent progressive disease, but actually this patient was getting better. Or this patient with renal cell carcinoma who was metastatic to the liver, this patient was receiving sunitinib, and you can see this lesion actually was getting bigger, but this lesion is actually improving because it's becoming less dense centrally. And also RECIST might miss these lesions. This is a person who has metastatic GIST to the liver. However, there are these new lesions all over, and RECIST does not take into account these lesions. So let's review some of the new ways of evaluating tumor response to therapy. First, there's the anatomic criteria, and that's for conventional cytotoxic therapy. And again, that's about 80% of my practice. Then you can use functional criteria, which include the CHOI, MASS, SACT, EASL, RECIST criteria, and they're tumor and treatment dependent. Metabolic criteria, PET-CT, PET-MR, PERSIST, which are tumor dependent. And then functional imaging, diffusion-weighted imaging, perfusion, and PET-MR. And then these are inadequate. You can use these, including immune response to these new criteria for immunotherapy. So let's talk about the anatomic criteria. Again, these have been around for the last 38 years. No problem understanding those. What about functional criteria? And this is very good for GIST tumor and tumors that respond not necessarily by shrinking in size, but becoming more cystic. So here's the baseline study. And then if you look at this lesion, by RECIST criteria, this lesion is getting larger, but actually it's improving because it's getting lower in density. The tumor size, the primary tumor, immense. I don't know if it's better or worse, but it is getting, in size-wise, but it is getting more cystic, so that's positive. And then ultimately, the primary lesion is diminishing in size. But again, this is an excellent response, but by RECIST criteria, this doesn't work. So one of the criteria you can use are CHOI criteria. And for a complete response, that's easy enough, disappearance of all lesions. Partial response, greater than 10% decrease in size, or a decrease in tumor attenuation by greater than 15% in terms of Hounsfield units. No new lesions, no obvious progression of non-measurable disease, and progressive disease greater than 10% increase in tumor in size and does not meet the criteria of partial response. So again, CHOI criteria are one way of assessing patients with metastatic GIST with cystic lesions in the liver. What about recurrent disease? Here's the primary tumor, and we have a nice response on the first scan. The second scan, the overall lesion's the same in size, but we're getting this mural nodule, and there's no room in the RECIST criteria for describing this nodule. However, they're modified CHOI criteria, in which this is called progressive disease, a greater than 10% increase in tumor size, and also any new intratumoral nodule. Then there are the MASS criteria that look at morphology, attenuation, size, and structure. And here's a patient who has a metastatic papillary renal cell carcinoma treated with sunitinib. And so here we can see the patient's lesion. Maybe it's a little bit smaller in size. This one is not. However, they are becoming more cystic. And again, with novel therapies, we have to interpret our scans with a grain of salt, and you might not want to use RECIST criteria for these patients. But I think it's important that you use the same criteria step after step after step. Then there's the SAC criteria, where you look at size and attenuation, and in the interest of time, I won't go over that, but unfavorable response, increase in size greater than 20%, new metastases, marked contrast fill-in, or new enhancement in a lesion that primarily showed hypodensity. So here's a patient with a metastatic renal cell carcinoma treated with sunitinib, and although the overall size had not improved, you can see this lesion is becoming far more cystic. Let's look at metabolic criteria next, which are tumor-dependent, PET-CT, PET-MR, and PERSIST. And I think this is a very helpful way of assessing whether your chemotherapy is working, because this chemotherapy is very expensive and can be quite toxic. And wouldn't it be nice after one cycle of chemotherapy to see if the patient is improving? So here's a patient with a GIST tumor, and this is the initial scan, and this is after one cycle of chemotherapy. Even though morphologically the tumor is the same in size, its activity has dramatically diminished in terms of the PET-CT. And this was a paper published in European Journal of Nuclear Medicine, and they can see PET-CT changes in which your therapy was active within 24 hours of initiating therapy. And then finally, functional imaging, and that will be part of the next talk. And this brings us to the point of efficacy. We want to find we heard this yesterday, we need to think about the 5 R's. Is our chemotherapy being effective? We have to have the right patient on the right chemotherapy, delivered at the right time, with the right dose and the right route. Now, the ability to assess tumor response early can lead to early termination of treatment in non-responders and will prevent additional toxicity from useless treatment and allow for earlier changes in therapy. Now, as I said, these modifications are quite expensive, and why submit the patient to 6 cycles of these agents if they don't work? In fact, a course of Avastin costs 30,000 American lira. And these agents can be quite toxic. Avastin can lead to perforation, and the patients also get this, a hole that develops in your stomach or intestine, and there's a toll-free number to call if you have any of these problems. And also in the package insert, the incidence of perforation with Avastin is up to 3.2%, and also they may have similar bleeding. Perfusion imaging, I think, is the way to go. Here we can, this is a case lent to me by Dr. Maselli, and you can see decreased blood flow with effective therapy. I've used it more commonly with CT. You look at regional blood flow, blood volume, blood flow extraction product, and permeability surface area. And let me show you some examples. Here's a patient. The blood flow at baseline was 90 cc's, and then after one dose of Avastin, it diminished to 40. The PET CT was still about the same. And so this is, some of our patients are on protocol where they're getting these toxic, expensive therapies, and they're getting early imaging, either with PET or PET CT, PET MR, or perfusion imaging to see if this cancer therapy is effective. And rather than giving them this long toxic cycle of chemotherapy, maybe after 1 or 2 cycles to see if you're having an effect. Here's another patient. Here's the baseline, and the SUV is 12.5. And notice after 2 weeks following Avastin, the blood flow would decrease to 63 and then 26. But notice the lag on the PET CT. A CT perfusion in rectal cancer, that's the one I have the most experience with. You look at these various parameters, and they all significantly decrease after your successful neoadjuvant chemo and radiation therapy. And diffusion-weighted imaging, that's also, we do that with every patient who has rectal cancer in our institution. The advantages of diffusion-weighted imaging, and we'll hear our next talk is on whole-body diffusion-weighted imaging. There's no ionizing radiation, no isotopes, no IV contrast, and it's very easy to get an ADC value, and it's very useful in rectal, breast, GIST, prostate, neuroblastoma, and osteogenic sarcoma. And after successful anti-cancer therapy, there's a decrease in tumor cell density due to necrosis and apoptosis, which causes a substantial decrease in water diffusion, and that leads to a decrease in the ADC values. And here's another patient who was successfully treated. And so again, when you give your chemotherapy, you get cell death and increased water, and that leads to an increase in your ADC value. If the ADC value is increasing, that's a good response. With little change in therapy, it's a poor response, and low ADC pre-therapy tend to be better responders. Should we change from RECIST to diffusion-weighted RECIST? Here was an article published in Radiology a number of years ago, and by week 1, they were able to determine who would be good responders. So here is a good responder. The tumor vascularity diminished quite promptly, although not terribly impressive on the morphologic imaging. You could see that this tumor was responding. Future clinical trials will be needed to investigate tissue or biomarker monitoring during treatment and correlate findings with disease progression. So I'd like to conclude by saying RECIST 1.1, I would say it's a mainstay for about 80% of my practice and patients receiving conventional cytotoxic chemotherapy. And these criteria depend on assessing changes in tumor dimensions. But unfortunately, they do not reflect other morphologic, functional, or metabolic changes that may occur with conventional chemotherapy, targeted chemotherapy, or immunotherapy. And again, I think you should have part of the requisition form from your oncologist what medication is the patient on, and you don't have to know the specific name, but if you see an IB or an AB at the end of it, you know that the patient's getting a novel therapy, and this patient may have an atypical response that is not effectively covered by RECIST. So we need to integrate new concepts in the evaluation of tumor response in this era of personalized medicine with molecular targeted therapy and immunotherapy. And again, be careful of any patient receiving an AB or an IB at the end of their medication. And I thank you for your attention.